This is CCTA case number 27. This is a 45-year-old man who was status post a Bentall procedure that involved an aortic conduit as well as an aortic valve replacement for a type A ascending aorta dissection. The procedure was done within about the past 6 months, and just within the past week or so he's been complaining of exertional chest pain. This is just a brief view of the three-dimensional set. You can see there has been clearly a median sternotomy performed, but let's start looking at the coronary arteries in particular. Let's begin by looking at the left main coronary. Appears to be very normal. There are 4 phases available for review, which can be shifted by changing the cine controls. As we proceed down the left anterior descending, the proximal portion appears to be normal. When we get to the mid segment, however, even though there's good distal flow, there is clearly an area of eccentric, non-calcified, obstructive plaque disease. Let's be sure by switching through each of the available phases to see if this is a true motion artifact. One of the ways to separate this out from a motion artifact is to look at this small diagonal, which would be adjacent to the area. And you can see that the diagonal remains relatively normal, but there clearly is continued abnormalities involving the mid portion of the LAD. The remainder of the vessel otherwise is unremarkable. Let's take a look at the circumflex vessel. Put that in the corner, center line, move down, circumflex. Again, very normal vessel. Change phases just to be sure, much clearer in this particular phase, and very normal looking circumflex artery. Let's take a look at the right coronary artery. Here's the right coronary coming off. This appears to be a small non-dominant vessel. You can see the aortic valve replacement sitting here. This is the conduit. There have been some coronary buttons applied to the conduit to allow the coronaries to have a usual kind of anatomic presentation. You can see, if you look at the sewing ring, you can see the sewing ring of the valve into the aortic conduit. So we have a patient who has clearly what appears to be evidence of focal obstructive disease. As to why this is the case, since he probably would have had a coronary arteriogram done 6 months previously prior to his aortic valve replacement. It's hard to say whether this is thrombus or non-calcified plaque, but just the same, he has obstructive disease. Let's take a look at the three-dimensional aspect just for a second. I'm going to do some additional sculpting of this area. I'm going to basically remove the sternum and include only the heart in the view. And as you look here, you can also see clearly on the three-dimensional views that this is focal obstructive disease involving the mid portion of the left anterior descending. For those that are not particularly familiar with the Bentall procedure, this is just a simple schematic from our lecture series showing that the aortic dissection is incised, a conduit is placed down into the aortic valve, although this could, in this particular case, also involve an aortic valve replacement, and then the coronary buttons are sewn directly into the Dacron conduit.